This is part 2 of our module, Drugs Acting on the Cardiovascular System, specifically drugs affecting the blood pressure, which is chapter 43 of our reference book. For the learning objectives, upon completion of this chapter, future nurses will be able to outline the normal controls of BP and explain how the various drugs used to treat hypertension or hypotension affect these controls. Describe the therapeutic actions, indicators, pharmacokinetics, contraindications, most common reactions, and important drug-to-drug interactions associated with drugs affecting BP. Discuss the use of drugs that affect BP across the lifespan. Compare and contrast drugs like captopril, losartan, diltiazem, nitroprusside, and droxidopa with other agents in their class and with other agents used to affect BP. Outline the nursing considerations, including important teaching points for patients receiving drugs used to affect the BP. We will now proceed into drugs affecting blood pressure. The cardiovascular system is the highway within the body that distributes oxygen, nutrients, and hormones and transports waste products such as carbon dioxide so they can be removed from the body. The blood in this system flows from areas of higher pressure to areas of lower pressure. The highest pressure in the system is always the left ventricle during systole, while the lowest pressure is in the right atrium. So we have three elements that determine pressure of cardiovascular system. So for that, we have the heart rate, which is the number of times each minute that the heart beats. Then the stroke volume, which is the amount of blood that is pumped out of the ventricle. And then we have also the total peripheral resistance, which is the resistance of the muscular arteries to the blood being pumped. The most important factor in determining peripheral resistance are the arterioles being the smallest in diameter, which made them able to almost stop blood flow into the capillary beds when they constrict, building up tremendous pressure in the arteries behind them and as they prevent blood from flowing through. Then we also have baroreceptors. So they are specialized cells located in the carotid sinus and in the aortic arch that serve as BP sensors mediating through ANS or autonomic nervous system. So they sense the blood pressure and relay the information to the brain so that a proper blood pressure can be maintained. So these baroreceptors are also sensory input that is received by medulla in an area called cardiovascular or vasomotor center. So if the pressure is high, then this medulla will stimulate vasodilation and a decrease in cardiac rate and output, causing the pressure in the system to drop. If the pressure is low, then the medulla will directly stimulate vasoconstriction and an increase in cardiac rate and output, thus increasing total peripheral resistance and raises the BP. So another compensatory mechanism for BP is the renin angiotensin aldosterone system, which was already discussed in chapter 42. The hypertension, which is an increase in the blood pressure above normal, known also to be the silent killer. So there are two types of hypertension, the essential and secondary hypertension. Essential hypertension is with no known cause. Total peripheral resistance is elevated, organs are effectively perfused, and no symptoms. So this affects 90% of patients who are hypertensive and is caused by conditions other than those related to renal and endocrine disorders. The secondary hypertension is the one that is with non-cause. And this affects 10% of patients who are hypertensive and is caused by secondary disorders of renal and endocrine disorders. Like for instance, pheochromocytomata, wherein there is a tumor in the adrenal medulla that releases a large amount of non-epinephrine causing hypertension. So that condition will be resolved once tumor is already removed. So take a look into that figure shown in the slide, which is about high blood pressure. So high blood pressure is a sign that the heart and blood vessels are being overworked. So if this is untreated, it may increase risk for coronary artery disease or CAD and cardiac death, stroke, RF or renal failure, and vision loss. So it will also cause enlargement of the heart. So the left ventricle will thicken because muscle mass constantly work hard to expel blood at greater force. So tiny vessels are damaged and destroyed by the prolonged force on the vessels, which is the underlying danger of hypertension. If tiny vessels of retina are damaged and destroyed, then vision loss will occur. If vessels destroyed include the glomeruli in the nephrons of kidney, then renal failure occurs. If fragile vessels in the brain are destroyed, loss of cerebral function occurs. Okay, the hypotension. If BP becomes too low, like in hypotension, the vital centers in the brain as well as the rest of the body may not receive enough oxygenated blood to continue functioning. So if not managed, hypotension may progress to shock, in which the body is in serious jeopardy as waste products accumulate and cells die from lack of oxygen, since it is the blood that carries the oxygen. So the hypotension can occur in following situations: when heart muscle is damaged and unable to pump effectively, blood volume drops dramatically due to severe blood loss or fluid loss, there's extreme stress, and the body's levels of non-epinephrine are depleted, leaving the body unable to respond to stimuli to raise the BP. The antihypertensive agents. So these antihypertensive agents or drugs can be used alone or in combination with one or more drugs that fall into one of the following categories. So we have the antihypertensive agents that include ACE inhibitors, angiotensin II receptor blockers, calcium channel blockers, and vasodilators. Then we have also other antihypertensive agents, including diuretic agents, renin inhibitors, and sympathetic nervous system drugs. So we'll go over them one by one as we go along with this chapter. So these antihypertensive agents will alter body's regulatory mechanism and is the best treatment currently available for hypertension, considering its unknown cause. Treatment does not cure hypertension but aimed at maintaining BP within normal limits to prevent damage. Not all patients respond in the same way due to varied factors that contribute to its person's hypertension. So patients may have complicating conditions such as diabetes mellitus or myocardial infarction that make it unwise to use certain drugs. So here's some lists of antihypertensive agents or drugs with its corresponding usual dosage and indications. Okay, I will leave them up to you to go over these drugs closer when you got your PLP, since they are self-explanatory, and this will be part of your independent learning as required by CMO 15. So we have there the ACE inhibitors, then the angiotensin II receptors blockers, okay, the calcium channel blockers. We also have vasodilators and other antihypertensive agents or diuretic agents. So We also have their drug therapy across lifespan. So one thing I would just like to give emphasis on, okay, for this slide is we have to remember that older patients should be especially cautioned about sustained release antihypertensives that cannot be cut, crushed, or chewed to avoid the potential for excessive dosing if these drugs are inappropriately cut. So we have this step care management of hypertension. So first treatment we have is lifestyle modification. So that will be instituted first. No, so like weight reduction, smoking cessation, moderation of alcohol intake, reduction of salt in diet, increase in physical activity. So if we have inadequate response for step 1, so that's the time we proceed into step 2. So, but then we have to continue the lifestyle modifications in step 1, and then still, if the BP is not acceptable, then drug therapy will be added. So for that, we can add a diuretic, ACE inhibitor, calcium channel blocker, angiotensin 2. No, it will just depend on the recommendations of the doctor per patient's condition. If step 2 is still inadequate, then we proceed into step 3. So we have to consider change in drug dose or class or addition of another drug or combined effect. So we have to note, fixed combination drug should only be used when the patient has been stabilized on each drug separately. Still, if the step 3 is not adequate, then we proceed into step 4. So all of the above measures are continued, and then a second or third agent or diuretic is added if not already prescribed. So as mentioned previously, the RAS or the renin-angiotensin system is one of the body's main reflexes for maintaining BP. So these 3 drugs aforementioned affect these reflexes to lower the BP, which is the approach done in the hypertension that has no known cause. So what are these 3 drugs? So we have the ACE inhibitors, the ARBs or the angiotensin 2 receptor blockers, and then the renin inhibitor. So another drugs we have for hypertension are the angiotensin converting enzyme inhibitors. So I will leave it up to you to look closer when you get your PLP. So this one, the ARBs, and then renin inhibitor, calcium blockers, which of course decrease also the blood pressure. Same way that it will also decrease cardiac workload and myocardial oxygen consumption. Then the vasodilators. If ever other drug therapies do not achieve the desired reduction in BP, it is sometimes necessary to use a direct vasodilator. So most of the vasodilators are reserved for use in severe hypertension or hypertensive emergencies. Like for example, the hydralazine, the minoxidil, and nitroprusside. Okay, so that is a continuation of vasodilators. And then we also have other hypertensive agents. So we have there a summary for our antihypotensive agents. So remember, hypotensive means low BP. So if the BP becomes too low, the vital centers in the brain and the rest of the tissues of the body may not receive sufficient oxygenated blood to continue functioning. So the severe hypotension or shock puts the body in serious jeopardy. It is often an acute emergency situation with treatment required to save the patient's life. So the first choice drug for treating shock is usually a sympathomimetic drug, no, the one that is shown in figure 43.3. So we have here a table for sympathetic adrenergic agonist or vasodepressor, which is the first choice for treating severe hypotension or shock. So which was discussed already in detail in chapter 30, in your previous topic. And then we also have blood-lowering agents like Milodrin, which is alpha-specific adrenergic agent used to treat orthostatic hypotension. Okay, when we say orthostatic hypotension, that is a hypotension that occurs with position change that interferes with a person's ability to function and has not responded to any other therapy. Then we also have blood-lowering agents, droxidopa, and then our antihypotensive drugs, nursing consideration, diagnosis, and planning, and of course, the implementation with rationale and evaluation. So that is the end for this set of slides. Thank you for your attention.